Welcome back to Diabetic Foot Files. I'm Dr. G, your podiatrist, wound care specialist, and limb salvage activist or advocate. Today's episode is one of the most board relevant, anxiety provoking, high risk clinical scenarios you'll ever face. Because when your diabetic patient is pregnant, you're no longer treating one patient, you're actually treating two physiologies, two circulations, and two futures. So today we're going to cover how pregnancy changes diabetic foot care, blood sugar targets in pregnancies, foreign bodies and trauma, imaging safety, anesthesia, antibiotics, and dressings, what not to use, and some of the board traps, like the boards that ask you questions about this, okay? So first we're going to cover the types of diabetes that happen in pregnancy. So type 1 diabetes, we all know, is pre-existing. Type 1 diabetes, they have the highest risk of neuropathy, infection, diabetic ketoacidosis, and poor wound healing. Type 2, often undiagnosed prior to pregnancy and increased insulin resistance as pregnancy progresses. And then the one that we always associate pregnancy with diabetes is the gestational diabetes, which is usually diagnosed within the second or third trimester, may still cause some hyperglycemia, increased infection risk, and delayed wound healing. But remember that patient having gestational diabetes does not mean they are low risk for wounds or infection. That is not true. So, blood sugar targets in pregnancy. They ask this question. This is like a high yield one when it comes to board. Pregnancy glucose targets, when they're fasting, they would like it like 95 or a little bit below that. 1 hour post meal, they want it like 140 or equal to 140 or a little under that. And 2 hours post meal, they want it like 120. Okay. You cannot use the standard diabetic targets when it comes to a pregnant patient because their diet glucose targets are different and stricter. So if a patient who is pregnant that has a glucose of 160, that could be pathological in a pregnant patient. It might be acceptable in a non-pregnant patient, but in a pregnant patient, that is a little bit pathological. So keep that in mind. So when we do a diabetic foot exam in a pregnant patient, because you'll have pregnant patients come to you as a podiatrist for foot swelling, pain. Some of them do end up getting plantar fasciitis. They do end up getting ingrown toenails because of the increased swelling. They can't fit their shoes anymore, things like that. So what pregnancy changes happens a lot in the lower extremities. You have increased edema. So when you have increased edema, you're going to have increased pressure points. So they might get more calluses as well. Because of the weight gain, their biomechanics are altered because of the hormone monoligament laxicity, their foot is more unstable, so there is foot instability. And then there are increased plantar pressures because of, the increased pressure points because of the increased edema in their lower extremity. So it does make them more prone to possibly having an ulceration, especially if they have a callus that's not being treated, right? Always document their pulses, their DP and PT, their cap refill, their skin temperature, their sensation, edema severity, and the callus formation. So, pregnancy related edema can mask infection. So, keep that in mind. So, one of the classics when it comes to boys and pregnant women who are diabetic is foreign bodies. So, common foreign bodies are like glass, wood, needle, metal, thorn. So, red flag. Puncture wound plus diabetes, I would say equals infection until proven otherwise. If you ever have a puncture wound and somebody just writes it off and say it looks clean and it's fine and you don't need antibiotics, go somewhere else. Go to somebody else and get a second opinion, okay? And another red flag is delayed presentation, persistent drainage, localized swelling, and pain despite neuropathy. But I've always told people that's a problem when it comes to that. So imaging. They ask this on boards too. Imaging when it comes to a pregnant person, what is the safest, right? So ultrasound, they might not have that as an option on the multiple choice because I looked and maybe they did, I'm not sure. I just remember that it was a difficult one. But imaging decisions, when it comes to that, the safest choice is ultrasound because we know women get the ultrasound in their tummy. So just in your mind, I would just correlate that. X-ray with shielding if it's indicated because you don't want to expose the person's body to any unnecessary radiation. Conditional, MRI without contrast. That's conditional, okay? If it actually is on an actual need to be basis, okay? But it has to be without contrast, okay? Avoid. You need to avoid a CT and you have to avoid MRI with gadolinium, okay? Unless it's life-saving, but let's hope you're not in that situation. Because why is that? Radiation risk to the fetus from a single X-ray with shielding is negligible and acceptable when clinically indicated, okay? So why should a CT be avoided in pregnancy? So why should a CT, I'm already repeating myself, but why should a CT be avoided in pregnancy? So the problem is ionizing radiation. CT uses X-ray, which are ionizing radiation. So why does ionizing radiation matter? Ionizing radiation actually damages the DNA, interferes with rapidly dividing fetal cells, which is going on during pregnancy. It increases the risk of congenital malformations, growth restrictions, neural development delays, childhood malignancy, which is dose dependent, and timing matters. Okay, so that's also another favor when it comes to how you abort things. First trimester is the highest risk when it comes to the CT because of the organic organs are being formed during that semester, right? That trimester. I say semester, trimester. Second to third trimester, you're at a lower risk, but it's not zero, okay? But regardless of anything, CT should be avoided unless the benefits outweigh the fetal risk, okay? But you shouldn't get a CT, okay? But keep that in mind. First trimester, you're at the highest risk because the baby is making organs and more risk of malformations, right? Also remember, a single extremity CT, like a foot and ankle, has very low fetal exposure, but still higher in radiation dose when it comes to than X-ray. It's higher dosage than X-ray. Often not necessary when MRI or ultrasound works, okay? And remember, when it comes to the MRI, it has to be without contrast, okay? But correct answer will always be avoid CT when reasonable alternatives exist, okay? So why is the MRI conditionally safe but contrast is not? So MRI itself, right? What does the MRI do? MRI uses magnetic fields plus radio frequency. It doesn't use ionizing radiation. So why the caution? Theoretically, the concern is tissue healing, acoustic noises, and unknown long-term fetal effects. The real issue when it comes to that is the gadolinium contrast. Why should gadolinium be avoided when it comes to anybody pregnant? It crosses the placenta. It enters the fetal circulation. It is retained in the fetal tissues, unfortunately, and the gadolinium is associated with rheumatological conditions, skin disorders, and actually stillbirths. So that's actually observational data. Okay. So board rule will be MRI without contrast is acceptable in pregnancy if needed, right? But MRI with gadolinium only if it's life saving. Okay. But hopefully would never present in that situation. Okay. God forbid. Now, foreign bodies. Remember we talked about different foreign bodies a little bit, right? And like, let's say the patient is pregnant, has a lot of swelling in their foot. A lot of times when you get past that certain trimester, you can't see your feet anymore. I'm just being honest, just from experience. I couldn't see my feet close to my end of my third trimester. I couldn't see my feet anymore, and my feet were swollen like crazy. Like I did not recognize my feet anymore. So what is safest when it comes to anesthesia for a pregnant person? Lidocaine, 1 or 2%. Remember, we all have max doses of certain anesthesias. So max dose, remember, this is boards love this, 3 to 4 milligrams per kilogram. Remember, without epinephrine and put that in bowls and caps for yourself without epinephrine. Avoid bupivacaine, aka Marcaine, okay? And why not use epinephrine, right? You're not supposed to, especially in a pregnant woman. Why not, right? Epinephrine causes like in end artery areas horrible. So epinephrine is not absolutely contraindicated, but it should be avoided when unnecessary. Okay. So why should epinephrine be avoided in pregnancy or used cautiously? Okay. Why? What does epinephrine do? Epinephrine causes vasoconstriction. Okay. Epinephrine physiology, the key concept of epinephrine is it is a alpha 1 agonist, so that causes vasoconstriction. It is a beta 1 agonist. I know I'm not saying it properly. For some reason, my tongue is not rolling for that one. But a beta 1 agonist, which increases heart rate, and a beta 2 agonist, which is causes bronchodilation. So in pregnancy, the uteroplacental blood flow has no regulation, and blood flow depends on the maternal perfusion. So that is really why epinephrine is so risky because it can cause uteroplacental vasoconstriction, which would cause reduced oxygen delivery to the fetus, which puts the fetus at higher risk of fetal hypoxia, and we don't want that. It increases maternal blood pressure. We don't want that. Can worsen preeclampsia and placental insufficiency, and it can cause end artery vasoconstriction, which causes a higher risk of digital ischemia and tissue necrosis, especially in a diabetic patient. So avoid epinephrine in end artery sites and pregnancy and in pregnancy unless necessary. So when they say end artery sites, like let's say the patient has what's it called again? Ingrown, right? Along the toe, right? So avoid that. Don't do that. No epinephrine. Like I said, it's not absolutely contraindicated, but it should only be used in case of emergencies. They say like anaphylaxis when the benefit clearly outweighs the risk and in small doses. But for now, the default answer is lidocaine without epinephrine. Okay. So, what are the wound care products and the dressings we should use in pregnant patients with diabetes? Saline, moistened gauze, foam dressings, hydrocolloids short term, and then alginates. You can use silver dressing short term and iodine based products. You should avoid using that long term. Avoid long term exposure with iodine because why? Chronic iodine exposure may affect the fetal thyroid function. Because it makes sense. You'll remember more if you remember why you can't use it. So, what antibiotics are safer for patients who are diabetics? Penicillins, cephalosporins like Aflex, clindamycin, and augmentin like amoxicillin clavulanate. So, what antibiotics should you avoid in a patient who has diabetes and pregnancy at the same time? Fluoroquinolones, tetracyclines, Bactrim, especially during the first semester, and aminoglycosides. A board favorite, boards love to say like clindamycin is a go-to for skin and soft tissue infections in pregnancy. So let's say the patient has a wound, right? They're pregnant and they have a wound and we have to debride it. Conservative sharp debridement should always be allowed and make sure you clear by vascular, right? Make sure the vascular assessment is good and that vascular is cleared. But in bedside procedures, always consider the diabetic pregnant patient's hemo, hemodynamic stability, consider their pain control and the infection severity, and then also avoid aggressive procedures unless necessary, and wound back unless infection is controlled and the obstetrician has cleared it. Okay, make sure of that. So tetanus protocol. So if the immunization, because you have to know tetanus protocol, especially when it comes to foreign body, right? If immunization is unknown or undated, Tdap is safe in pregnancy, preferred during the 27 or 36 weeks, but may be given earlier if the wound requires it. Pregnancy is not a contraindication for tetanus prophylaxis, so keep that in mind. So, what like certain answers you should avoid when it comes to boards or even questions when it comes to wound care and boards, things like that. If they say avoid all imaging, that's going to be wrong. If they say safe silver is always safe, that's always wrong. If they say gestational diabetes is low risk, that's wrong. And if they say epinephrine is forbidden, okay? Because like I said, they want the best right answer. All the answers, majority on the boards are right, but they want the best right answer, right? So, correct thinking, you have to think risk benefit analysis, multidisciplinary care, and fetal and maternal safety. So, let's do some quick questions, really. Best imaging for a wooden foreign body in a diabetic pregnant patient, ultrasound. What's the best antibiotic for a diabetic pregnant patient with cellulitis, clindamycin? What's the safe local anesthetic for diabetic pregnant patient, lidocaine without epinephrine? And always check the bottle too and confirm. What is acceptable? Is a foot X-ray acceptable in a pregnant patient? Yes, with shielding. And then what is the blood sugar target? Fasting wise, it's going to be equal to or less than 95. Okay. So let's do some quick questions when it comes to diabetic foot care in a pregnant patient. So question one, a 28-year-old woman with gestational diabetes at 30 weeks gestation presents with a plantar puncture wound from stepping on a nail. Okay. She has, remember when you think of stepping on a nail puncture wound, you think of what? Right? Pseudomonas, right? Yeah. Yeah, puncture, pee, all that stuff. But she has neuropathy, she has mild swelling. What is the best initial imaging for her? A CT of the foot, B, a MRI with gadolinium, C, a ultrasound, or D, no imaging due to pregnancy. The correct answer is C. Ultrasound is safe in pregnancy and excellent for detecting foreign bodies, especially wood and non-radiopaque objects. Which blood glucose target is most appropriate for a pregnant diabetic patient? A, fasting equal to or less than 110, fasting equal to or less than 95, postprandial equal to or less than 180, or a random glucose equal to less than 200. The correct answer is B, fasting equal to or less than 95, okay? So, like I said, pregnancy always requires stricter glucose control than non-pregnant diabetic patients, okay? So, a pregnant patient with type 1 diabetes presents with a foot abscess. Which antibiotic is most appropriate? A, ciprofloxacin, B, tetracycline, C, clindamycin, or D, Bactrim. Correct answer is C, clindamycin. Clindamycin is safe and it covers gram-positive and anaerobic organisms. Which imaging modality is acceptable for suspected osteomyelitis in a pregnant patient with diabetes? A CT, B, MRI without contrast, C, MRI with gadolinium, or D, a nuclear bone scan. And this is the four options now. You see, there's no ultrasound or anything in there. So the best correct answer would be MRI without contrast. Okay. Remember, gadolinium is avoided unless absolutely necessary. So it is an MRI without contrast. Which local anesthetic is preferred for a pregnant diabetic patient undergoing foreign body removal? A, bupivacaine with epinephrine, B, lidocaine with epinephrine, C, lidocaine without epinephrine, or D, marcaine without epinephrine. The answer is C, lidocaine without epinephrine. Okay. A pregnant patient with a chronic plantar ulcer, which topical agent should be avoided long term? A, saline gauze, B, alginate, C, silver dressing, or D, foam dressing. What do you think the answer is? The correct answer is C. You should avoid prolonged exposure of silver dressing to any pregnant patient because it may affect the fetal development. So keep that in mind because a lot of wound care specialists do love a silver alginate dressing. So keep that in mind if the patient is pregnant. And remember, I love iodine as much as anybody else, okay? But remember, you have to avoid the iodine because it can affect the fetal thyroid, okay? Next question. Pregnant patient presents with edema, erythema, and warmth of foot. Sounds like red hot swollen foot, right? Why may an infection be harder to detect in a pregnant patient? Is it A, because of decreased estrogen, B, because of the pregnancy-related edema, C, because of the lower immune response, or D, because of the increased blood volume? The answer is B, because of the pregnancy-related edema. That is inevitable, which sucks a little bit. Which antibiotic is contraindicated for a pregnant patient? Is it A, Augmentin, B, Cephalus, like Keflex, C, ciprofloxacin, or D, clindamycin? Correct answer is ciprofloxacin. Now, a pregnant patient, diabetic patient who steps on a glass, X-ray ordered. Which statement is true? X-rays are absolutely contraindicated. B, shield foot X-ray is acceptable. C, ultrasound must be always used instead, or D, radiation exposure guarantees fetal harm. The answer is B, shielded foot x-ray is acceptable. Remember, radiation dose from a foot x-ray is minimal and safe with shielding, okay? Next, which statement regarding gestational diabetes is correct? A, it has no effect on wound healing. B, it carries the same risk as type 1 diabetes. C, it increases risk of infection. Or D, it resolves immediately after delivery. The answer is C, it increases the infection risk. So I'm going to do two or three more questions. Next, a pregnant diabetic patient requires a tetanus prophylaxis. What's the best response? A, delay until postpartum. B, do the Tdap. Okay, so Tdap is contraindicated. That's a B. C is administer the Tdap if indicated, or D, give tetanus immune globulin only. The correct answer is C, administer the Tdap if indicated. So if it's a pregnant diabetic patient that requires a tetanus prophylaxis, you can administer the Tdap if indicated. Okay. Next, I think this is going to be the last one I do. Why should iodine-based dressings be used cautiously in a pregnant patient? Because I love me some iodine. Why? Why should it be used cautiously in a pregnant patient? Is it A, because of maternal hypertension, B, the risk of fetal thyroid dysfunction, C, risk of preterm labor, or D, risk of placental abruption? Answer is B, risk of fetal dys- fetal thyroid dysfunction. Okay, so keep that in mind. Okay, so I hope this episode was very helpful. So, what is the takeaway when it comes to pregnancy and diabetes? You can use ultrasound and you can use an MRI without contrast. Those are safe. Blood sugar goals are stricter. Clindamycin is going to be your most valuable antibiotic player in the game. Lidocaine without epinephrine is the safest, and avoid long-term use of silver and iodine. And when you're treating a diabetic patient who is pregnant, you're treating two patients at the same time. So this is Diabetic Foot Files, and we're taking care of pregnant patients as well. And I want everybody to treat them safely. So this is Dr. G with Diabetic Foot Files. Take care of your feet because they take care of you. And, congratulations to all the new mummies out there.